Okay, well, hi everyone. Welcome to Veterinarians Without Borders One Health Day webinar. Veterinarians Without Borders, we would like to start by acknowledging our board members, staff, volunteers, donors, and supporters who live and work on the traditional territories of many Indigenous peoples across North America, the traditional stewards of these lands who've been living and working on them for thousands of years. Our head office is situated in the unceded and unsurrendered territories of the Anishinaabe Algonquin Nation, whose presence reaches back to time immemorial. My name is Kristen Rodriguez. I'm the Director of International and Humanitarian Programming here at VWB, and I would like to officially welcome you to our One Health Day webinar. As you may or may not know, One Health Day is observed annually on November 3rd and serves as a global platform to raise awareness about the interconnected health of people, animals, and the environment. So to mark this day, we've invited a multidisciplinary panel of One Health specialists and colleagues to dive into the question, how do community-led One Health teams help to bridge health gaps and build resilience? So specifically, our panelists today are all partners in the Global Affairs funded COHERS project. They will share their experiences as researchers and One Health professionals in building collaborative solutions to detect, prevent, and respond to diseases like anthrax and cysticercosis in Rwanda and Senegal. So during this webinar, we do encourage your active participation. And following the speakers' presentations, we'll open the floor for a question and answer period. So you can wait until the question and answer period to submit a question, or feel free to submit it as we go, and we'll come back and address them at the end of the presentation. So to give you a little bit of background, at Veterinarians Without Borders, we do embrace the One Health approach, which recognizes the interconnectedness of humans, animal, and environmental health. So this approach is particularly important in regions where high interaction between people, animals, and ecosystems increases the risk of zoonotic diseases. So zoonotic diseases are those that spread between animals and humans. So specifically, our COHERS, or Community One Health Empowerment in Rwanda and Senegal project, is a 4-year initiative that directly reaches over 127,000 people in Rwanda's and Senegal countries. COHERS is designed to empower communities to improve health outcomes through One Health approaches to prevent, detect, and respond to zoonotic diseases like anthrax and cysticercosis. The program uses a gender-responsive approach by focusing on marginalized women and girls who are most vulnerable to zoonotic diseases due to their roles in household livestock care, water, and food preparation. So this approach empowers women to take leadership roles in health interventions, address inequalities in access to resources, and also improve decision-making power. So COHERS works with local and international partners such as UGHE, the Center for One Health in Rwanda, WaterAid Rwanda, and AVSF Senegal, as well as the University of Guelph in Canada. Specifically, the project activities include establishing and training One Health teams, which include community health workers, animal health workers, and WASH, which is water, sanitation, and hygiene specialists. So bringing them together to form local One Health teams. The project also then will lead community sensitization and outreach through One Health Days to enhance community knowledge and practices to supplement these One Health teams. And it will also provide resources like vaccines, testing supplies, and treatment medications to support disease control, as well as build climate-resilient WASH infrastructure in Rwanda to reduce disease risk. So today, specifically, we're excited to hear from our distinguished panelists, each bringing valuable expertise in One Health initiatives and collaborative solutions driving the COHERS project forward. So first, we will hear from Dr. Cate Dewey, who will share her extensive One Health research experience on community behavior change in the pig value chain. She will also link how this work informs her current role in the COHERS program, specifically in training One Health teams. Following that, we'll hear from Dr. Prince Rwagasore, who will discuss the early stages of building One Health capacity in Rwanda, including the curriculum, training, and upcoming activities planned for the One Health teams. Finally, Dr. Anselm Shiaka will discuss the collaborative research with COHERS and these findings and how these findings are shaping One Health strategies in Rwanda and Senegal. So without further ado, I'm going to introduce Dr. Cate Dewey, who is the Assistant Dean and Professor at the Ontario Veterinary College at the University of Guelph. So she is the inaugural director of the One Health Institute at the University of Guelph, where she leads initiatives focused on zoonotic disease prevention. So she's been a professor at the University of Guelph since 1995 and previously served as the chair of the Department of Population Medicine for 11 years, where she led the redesign of the DVM program and helped develop the Master of Public Health program. So she is widely recognized for her commitment to capacity building and advancing One Health research. So with that, we will pass it over to Cate for her presentation.
Thank you so much. Good morning and good afternoon, everyone. It is my great pleasure to be with you today. And as was already said, I'm going to share some community health work that I did in Kenya and Uganda with the aim of reducing the prevalence of the tapeworm in the communities where we were working. This research, I must highlight, was the focus of the PhD work for my students, Florence Matua, Mike Levy, and Natalie Carter. What we know is the pork tapeworm, Taenia solium, is responsible for 70% of epilepsy in the world where there's poor hygiene and people raise pigs. Next slide, please. So if you're not familiar with the Taenia solium tapeworm, I'll just quickly share the life cycle. So a person will have the adult tapeworm in their intestine. That tapeworm will shed 50,000 eggs a day on the stool of the person. If a pig gets access to the stool, the pig will eat that stool, and the egg in the intestine of the pig will actually migrate into the body of the pig, mostly going to the muscle, which of course is the pork, and in that muscle, the tapeworm egg turns into its larva. This is a visible lesion, as you can see in the bottom left. That then, if then another person eats infected undercooked pork, that person also gets the tapeworm. Just if you'll push forward, please. 3 times, I think. Thank you. So how do we stop this? Well, first of all, we encourage people to use a latrine when they defecate, and we encourage people who have pigs to keep them tied. And we encourage butchers to have the pork inspected by a veterinary inspector. And people who are living in regions where this tapeworm exists, we encourage people to cook the pork well if they're going to eat it. Next slide, please. So how does the epilepsy happen? A person who inadvertently consumes a tapeworm egg, and those are microscopic, so you wouldn't know you did that. Those tapeworm eggs distribute around the body of the person, and they can go to the brain of the person. In the person, just like in a pig, the egg turns into a larva, and in the brain, it causes these space-occupying lesions that lead to epilepsy. So in order to prevent this, we encourage people to use a latrine and encourage them to wash their hands with soap and water after they defecate. Next slide, please. So we used a transdisciplinary approach. We engaged community members in these areas where we were working across the entire pig value chain: farmers, butchers, consumers, government extension workers who supported the farmers. And we were in the communities for multiple weeks before we began the research. We needed to find out from people in the community what their concerns were and how we could best support them. Pigs were being raised in Kenya. Pigs were being raised by women and being used as a financial savings vehicle. The pig was sold when there was an emergency for needed in the family for school fees, medicine, clothes, and food between harvests. Farmers said they let their pigs roam because they couldn't afford to buy food for the pig. When we talked about the link between the tapeworm and epilepsy, people in this region of Kenya had not heard about that before. Next slide, please. So our project, the entire project went from 2006 to 2018, but the project that began was with Florence Mutua, who's a Kenyan. And in her part of the project, we did a random sample of 288 farms. And we interviewed farmers every 5 months. And in 2006, we did farm visits as well as a workshop for the farmers. And then 2008, we did another workshop where we presented research data and also some additional information for them and found out if the farmers had made any changes. We left that community for 2 years and we came back in 2010 and we did outcome mapping where we determined whether or not there were any long-term behavior changes in the community. Next slide, please. We used a training of the trainer model where we trained the government staff and then we facilitated them to go village to village training the farmers. Next slide. We used a gendered approach. We understood that not all farmers could go to the training, and in particular, women like this woman. She had young children and a lot of farm responsibilities and was not available to take half a day off to go to the training. So when we went to those farms, we actually did one-on-one training about topics that were covered in the larger training. Next slide, please. And Natalie Carter, she did a study on looking at what kinds of feedstuffs were freely available to the farmers that they could actually use to feed the pigs. And so we worked with swine nutritionists to identify the nutrient value of these feeds. And we actually made a complete feed out of mostly freely available foods, as you can see, including banana leaves and sweet potato leaves. But there was a little that they had to buy. They had to buy the dried fish for protein and the salt. Next slide. Oh, no, not next slide. So the conclusion of this was we did a 8-month feed trial. We compared the growth rate of pigs after weaning on this locally available food versus commercial ration. And our conclusion from that study was that it was important to feed commercial ration for the first 4 weeks after the pig was weaned. The pig grew very well on commercial ration. As you can imagine, a newly weaned pig doesn't eat very much, but we needed to get them to a certain weight in order that they could properly digest this freely available food. Next slide, please. So in 2010, we asked the farmers if they had made changes based on what they learned. So you can see that in 2006, only 34% of the farmers kept their pig confined, but in 2010, it was 85%. That's a huge change. 58% said they improved the feeding of the pig. We established a way to estimate the weight of the pigs using a tape measure. Everybody did that before they sold the pig. Consumers told us that they only bought inspected pork, so the pork that had the stamp on it. They cooked the pork longer. A few people built or repaired a latrine. And interestingly, when we visited the farms, the percent of farms with a positive pig dropped from 15% to 9%. Next slide, please. We included all of the butchers in the area that bought pigs from these farmers. And what they wanted was they wanted to know how to run their business better. So we gave individualized education on business accounting and profitability. I think it's really important that you always give back something that the community wants when you're doing training. And then we did group education on pork safety. 80% of the butchers sold cooked pork as well as raw pork, so they needed to have the same kind of education. Next slide. When we interviewed the butchers in 2010, we asked them if they had made any change since we had done the training. So if you can see the little superscripts, the A's represent us just saying, did you make a change? And then if they did, we'd say, did you make any other changes, until they didn't have any more changes. And the B's meant we said, have you improved your cleanliness, or do you clean your countertop? So that's how that's the difference between these numbers. But you can see that some butchers were only purchasing tethered pigs. A lot more butchers just said that they would always use a slaughter slab in order to get the pigs inspected. That wasn't happening before. Several, almost 50% or more than 50%, said they stored their meat in a better way so that it was less likely to be contaminated. And many improved cleanliness. And then in the second to bottom, you can see that some of the butchers, half of the butchers, were buying a pig with another butcher so that they could sell fresher meat. Next slide, please. So how does this relate to the project in Rwanda? Well, we learned over those years the training that we did had a big impact on the community that we were working in. So the training that we put together for the trainers in the project in Rwanda included much of the same information that we used when we did the training in Kenya and Uganda. The difference is, I guess I should highlight that. We're training about the Rwanda policy in One Health. There wasn't one in Kenya in those days. We're training about more impactful gender approaches, which we didn't do to the extent that they're going to do on this project. We are using a train the trainers model. So we have a veterinarian and a public health expert who both have experience training in communities and training farmers. And we did 3 full days of training for them. The One Health teams are going to be receiving 10 trainings, 1 a month for 10 months. And I think the other speakers will probably talk more about that, so I won't. Each training will do a pre-training survey and a post-training survey on the same day. And it was very exciting to see what happened in this first training that was in October. So at the beginning, the people who came for the training didn't know what One Health was. And at the end of the training, 127 of those that were trained were able to say that One Health was a combined health approach. So that was exciting. And 32 wrote something similar to One Health means a combined health approach to improve the health of people, domestic animals, wild animals, and the environment. So very exciting that in that one first training that we changed the needle so much, and they seem quite excited about working together. Thank you so much for your attention, and we'll move to the next speaker.
Great. Thank you, Dr. Dewey. That was a fantastic presentation. I think it really helped set the stage for building off of your previous work and how that has built in and been a key component in kind of launching this COHERS program. So next, our next speaker is Dr. Prince Rwagasore, the Research Associate at the University of Global Health Equity, UGHE Rwanda. So Prince is a physician and a global health leader whose research focuses on the intersection of human, animal, and environmental health, with a strong commitment to promoting social justice and health equity. So Prince's work addresses neglected tropical diseases and zoonotic diseases. He holds a medical degree and a master's degree in global health delivery with a specialization in One Health. So with that, I'll pass it over to Prince.
All right. Thank you very much, Kristen. It is a pleasure for me to be talking today about community One Health team strengthening in Rwanda. Yes. So to start, I want to take you through the history of One Health in Rwanda because I think it's necessary for everyone to understand why we decided to create and to strengthen the One Health teams. So first of all, in 2014, that's when Rwanda established its first national One Health strategic plan, but there were no focal personnel who were responsible to implement it. And then in 2021, the existing national strategic plan was revised, and it was adopted by the three ministries, the Ministry of Health, the Ministry of Agriculture and Animal Resources, and the Ministry of Environment. And in that same year, they also managed to establish a One Health unit, which is still currently operating, and it's operated under the Rwanda Biomedical Center. So the One Health unit that was created in 2021, it was given so many mandates, but I'll only talk about two major mandates. The first one is to identify priority diseases that the country was going, to focus on. And these diseases mostly are the zoonotic diseases and neglected tropical diseases. And the second one was to now establish surveillance mechanisms for those priority diseases to ensure that we capture all the data and identify when we are at risk of having an outbreak. And in case of an outbreak, coordinate the response to those outbreaks. So at the central level, we have that structure which is working, which is operating very well. But when you look at the community level, there is really no focal personnel who are responsible for that. And the implication of that is that, as probably some of you know, in the past 5 years, Rwanda has seen 5 different outbreaks, which includes COVID, which was a pandemic globally, Rift Valley fever, monkeypox, and recently Marburg. So among those 4 outbreaks that we had, all of them actually are from are of zoonotic in nature. And among those 4 outbreaks that we had, one of them, specifically the Rift Valley fever, is believed to have originated from low adherence to animal trade and animal slaughtering regulations. And this is a practice which would be observed in the communities rather than at the central level. So Rwanda is known to have a strong history of coordinating outbreak responses. We've seen that during COVID, we saw it during RVF, we still see it today during Marburg. But after the response, when you look in the communities, there's no ongoing community-based surveillance that is done. That means that we might still be at risk of getting another outbreak anytime because there is no surveillance that is being conducted. And that's why as COHERS, we decided that it's better to create these One Health teams in the community and strengthen them so that they can be able to do surveillance. So during creation of the One Health teams, we thought it would be better, and we believe it's better to leverage existing systems because the people who are already in the systems know the community and they've been working with the government. So it would be better to strengthen them, to train them and capacitate them to do the work that we would like them to do. So we leveraged 3 different groups of people who exist at the community level in every village. The first group is the community health workers. Rwanda has an army of more than 45,000 community health workers who are distributed across the country, and they are doing a great work, controlling some diseases, including malaria, and also improving maternal and child health. But we wanted also to train them so that they can be able to identify some of these zoonotic diseases and other One Health diseases. The second one is the community animal health workers, which is also a system that is present already in every community, and the community hygiene clubs, which usually work hand in hand with community health workers to treat, control, and prevent diseases that are associated with poor hygiene, like malnutrition and diarrhea diseases. So after establishing the teams, a team which is composed of 3 people at the community level. We developed a curriculum together with the University of Guelph and WaterAid. The University of Guelph took a lead on that. And these are the 10 topics that we come up with, and we are training these community members or community-based workers in these 10 topics. So they will do the training for 10 months, and we have gender transformative approach, we have intersectoral collaboration, how are they going to work together, not just community health workers working in silo, but collaborating together to prevent these diseases. So after the training, what is going to happen? And even during the training, what do we expect from the One Health teams? 3 things. We divided it into 3 major categories. The first one is prevention. The second one is detection. The third one is response. So as preventive measure, we expect them to organize and host One Health days in the communities where they will be training the people in how to prevent some of these zoonotic diseases that are prevalent in the communities. The second one is to conduct household visits and look at the behaviors and other activities that people are involved in, which might put them at risk of developing some of these diseases. We also intend to host a radio show with the One Health teams where they will be talking about the realities and what they've been doing in the communities. The second one is the detection of Taenia solium, or identification of cases. They will be doing this in collaboration with the University of Global Health Equity, where they will be collecting not only data, but also some samples to do analysis and see the prevalence rates of teniasis and cysticercosis. They will also administer a rapid One Health surveillance tool, where they will be looking at different, not just Taenia solium, but different One Health diseases that may arise in the communities. And as a response measure, they will distribute different drugs, specifically the ones for teniasis and cysticercosis in the communities. And also they will be reporting any case of adverse effects or anything that arise in the community which is unusual. So in the future, what do we hope to have achieved? First of all, we hope that the One Health teams will support the government to conduct systematic surveillance in the communities, and in case there's any outbreak, they will be ready to respond together with to work together with the government to respond to the outbreak. And secondly, we hope that they will disseminate the knowledge that they will gain or they will acquire during the trainings with the fellow volunteers in the communities, so that we can have many people who are ready to conduct surveillance, but also respond to this outbreak. And thirdly, we hope that they will contribute to eliminate zoonotic diseases, and in particular, Taenia solium, that means teniasis and cysticercosis, in an acceptable and culture sensitive way, since they live in the community, they know what people usually do, and they know what is acceptable for them. The fourth thing, which is very important to us, we hope that it will showcase the value of community-based workers in One Health systems, in community awareness, in surveillance, and in responding to different diseases. And we also hope that it will highlight women leadership in community programming. Yeah, so thank you. If you have any question, I hope that you will put it in the chat box.
Great. Thank you, Dr. Rwagasore. And so as was mentioned, please, if you do have any questions, do put them in the chat box for our question and answer period at the end. So with that, I would like to move on to our next speaker, Dr. Anselm Siaka, the Assistant Professor of One Health at the Center of One Health at the University of Global Health Equity in Rwanda. So Anselm is a veterinarian and a molecular researcher specializing in zoonotic pathogen diagnosis and antimicrobial resistance. At the UGHE in Rwanda, his work focuses on reducing antimicrobial use in food animals and mapping the prevalence of resistant pathogens. So Anslem is also a member of Rwanda's Neglected Tropical Disease National Sub-Technical Working Group, contributing to efforts to eliminate NTDs in the country. So with that, I will pass it over to Dr. Shiaka. Shiaka, you're muted. There we go.
Yep. Good morning and good evening, depending on where you are joining us from. Thanks for joining us. I would like to thank VWB for setting up this opportunity so we can discuss the One Health operationalization, taking COHERS as a case study. I'm going to mostly repeat what other colleagues have been presenting. Mainly, I want to bring on board the collaborative research component of COHERS and how the findings are more likely to be influencing, our strategies moving forward. So my presentation will be super fast. I want to take you a little bit back, discussing the structure of pig production in Rwanda. I'm doing so to give everyone, the context on why COHERS is really intervening in solium fight. Next, I will be talking about why we need a multidisciplinary team. I want to give you a very abstract context so we understand why we need such a holistic team to fight Taenia solium infection. Third, I will be talking about COHERS approach and team toward this specific cysticercosis study. And I will be concluding talking about expected reasons. Expected reasons because we have not yet obtained field-based, results. So in Rwanda, similar to other neighboring countries, we have typically three types of pig production, a small scale, medium scale, and large scale pig production. The small scale is more dominant, far more dominant, and it is done mainly by farmers who are looking for ways to save money, who are looking for fertilizers for their crop. While the medium scale pig production is implemented by people who have other jobs, other occupations. They have probably heard that pig production may be a great opportunity, and they invested money to try and get benefits. For the large-scale pig production, the owners spend their working hours planning and supervising farm activities, and they usually have many grown pigs that can be over 800. Allow me to just focus on the first category, the small-scale pig production, because of two reasons. The first reason, it's the predominant system, but it's more relevant to T. solium infection, which attracted COHERS team attention. I'm going to narrate a very small story of what happens in this type of pig production systems. Many farmers will usually start their pig production with a winner piglet, like the one you are seeing on my slide. The piglet costs around 11 USD, and it will be fed mainly on grass and crop residues and be treated. And after 10 to 12 months, the farmer will sell it for approximately 48 to 50 USD dollars. So from this money, the farmer will use part of it to buy some food for the family, to pay for school fee for the kids, to afford the health insurance for the family, but they usually keep some money to again buy another small piglet to start again the cycle. This is the the good scenario which happens. So unfortunately, sometimes there are problems. That small weaned piglets which is raised, is usually taken to the market, but at the market, people will usually check whether it has some cyst on the tongue. And when it has a cyst, you know, the traders will buy it, but they will buy it at a discounted price. So instead of paying the 50 USD, they will pay something like 15 to 20 USD. So the farmer can no longer afford, you know, paying insurance fee. He will no longer afford to save some money, and this is not good. Sometimes the farmers are not happy. They would prefer to take back the pig home, and they do backyard slaughtering, but this is also associated with issues. He may be able to sell it to the neighbors at a discounted price, but again, this will pose another public health issues because people will catch Teniasis by consuming such meat which are never inspected by veterinarians. So because of this scenario where the people lose money, lose potential income, and where the public health is at challenge, COHERS wants really to provide the One Health solution to controlling T. solium infection. This is not easy, and I will be taking you through why, you know, we need a strong multidisciplinary team as a key to controlling, you know, such a complex disease. Professor Cate explained very well the life cycle for Taenia solium, but briefly, when you look at this life cycle, you know, T. solium parasite causes Teniasis in human. The affected humans will be shedding eggs of T. solium when they defecate, and with poor hygiene and sanitation, the eggs will contaminate the environment, including crops, grass which might be fed to pigs, and water. Then pigs or humans can be infected by the eggs of Taenia solium, hatching into larvae and becoming cysticerci in their muscles. The infected subject will develop cysticercosis, and if the cysticerci migrate in the central nervous system, the affected human individuals will suffer from neurocysticercosis with seizures and other epileptic symptoms. The key messages here are two, you know. First, this parasite can affect humans by causing Teniasis and cysticercosis, but also it can affect pigs, causing, you know, cysticercosis in these animals. The second message, the parasite really circulates between humans, pigs, and environment, and this actually makes its control very, very challenging. How do we break the cycle for this type of infection? We need really the contribution of many actors. For example, public health expertise will be needed to provide the human treatment, so we stop the human from shedding the eggs of T. solium and thus contaminating environment and pigs or humans. We will need the public health expertise to improve hygiene and food safety awareness in the public. We also need veterinarians to advise farmers on how best to keep their pigs, for example, permanently in pens, well fed, but also we need them to provide vaccines and antibiotic because those solutions do exist. Finally, we need veterinarians so they can strengthen their meat inspection strategies. By doing so, there's a chance that they slightly reduce the amount of T. solium entering the food chain. We need environmental experts to help us, you know, taking people through behavioral change by advising them, for example, on how best to use fertilizers. You may know that some people keep using fecal matters as fertilizers for their crops. But we need also environmental expertise to improve the hygiene and sanitation so we can break clearly the cycle for Taenia solium. You know, this is very general, I want to show you how, as COHERS, we are taking seriously the fight against this Taenia solium, attacking it in various angles. So first of all, we are creating One Health teams, as my two colleagues explained. We will continue to build the capacity for the teams, but also for the general population on zoonotic diseases, particularly Taenia solium infections. This first intervention is likely to impact all the general population, all the aspects relevant to Taenia solium control. However, as you may know, education alone is not enough. And this is why we will also be implementing other specific activities, such as provision of praziquantel to treat humans. We'll be providing oxfendazole and Sysvax to pigs, so we can treat and prevent infection in pigs. But we will be also improving latrines and work to change the behavior of people, so we keep our environment safe and we protect humans and pigs. This work, as you can see, requires a multidisciplinary team. With the funding from VWP, WaterAid Rwanda, and UGHE, the Center for One Health, we will be coordinating and supervising all activities in Rwanda here. But we are not working alone. We are very grateful for the wonderful support and the usual great discussions with partners from the Institute of Health Economics in Canada, University of Guelph, but also Johns Hopkins, who support us along the journey. We can't do this alone. I'm sure we have the academic expertise, scientific expertise, but we need further political and community buy-in and collaboration for a successful initiative. In this table, I have tried to summarize the further support which we sought and which we need for an effective project implementation. We have already secured support, and we will continue to seek support and guidance from the central government, local government, but also the community. From the central government, we are grateful for the support from the Ministry of Health through its implementing organizations such as Rwanda Biomedical Center and the Rwanda Food and Drug Authority. We are working closely with the Ministry of Agriculture and Animal Resources and its implementing institution, that is Rwanda Agriculture and Animal Resources Board. And at local level, we are working with the district directorates of health and agriculture, as well as district hospital, health centers. While in the community, as Dr. Prince explained, we are working with the community health workers, community animal health workers, and members from the community hygiene clubs. This type of collaboration is crucial to ensure ownership, regular consultation, and adjustment as we implement the project. I will finish with this slide. We have not yet obtained infection-related data. So this slide shows anticipated findings and possible reasons as we move forward. We, of course, hope to create One Health teams, as my two colleagues explained. We want to improve WASH in the research area. We want to reduce cysticercosis, and we want to be contributing to farmers' well-being and income. Now, for this type of multidisciplinary team, there are some anticipated reasons. I'm sure we'll be having many more reasons. But at the end, I'm sure we'll be generating reasons on do's and don'ts of transdisciplinary collaboration, which are reasons needed actually to support the advocacy for similar One Health interventions. We are looking forward to vibrant One Health teams, which will be instrumental for early surveillance and actually ambassadors on how best to take care of livestock for optimal benefits for all. We want to provide facts on a cost-benefit strategy to eradicate T. solium, considering community perception and needs. And finally, we want really to document the gender role in fighting zoonotic diseases similar to T. solium infection, which we are studying. Thank you, and I welcome any question.
Thank you, Dr. Shiaka, for that insightful presentation and the overview and details of the work and strategies that are part of the COHERS program in Rwanda. With that, we would like to open the question and answer section of this webinar. So if you do have any questions, please put them in the chat. I'll start by launching off with some of the questions that are already there. So our first question is addressed to Prince. The question is, do the community health workers receive a stipend or salary for participation, or is it on a voluntary basis? And if paid, how is the fee determined?
All right, thank you very much. So there is no salary for the community health workers, but usually they're paid some stipend for the work that they do. And also the government of Rwanda has really encouraged them to work into cooperatives, and the government will send the money through the cooperative to support them. So the idea is that the money that the government sent in the cooperatives is going to be used for income generating activities. Yeah.
Great. Thank you, Prince. The next question is for Cate. In your research on neurocysticercosis and epilepsy, what were some of the most effective strategies in helping community members understand the link between pig health and human health?
Thank you for that question. So first of all, there were a large number, relative to what you would see in Canada, a large number of people who had epilepsy. And many people in the communities we worked in had tried various treatments for epilepsy. And as we understand, once you have epilepsy, you have to be on medication for a long time, but it doesn't go away. And there was no facility to enable the people who had epilepsy due to the Taenia solium to actually afford to go to the hospital and have the extensive treatment that you would have in Canada. So first of all, it was very important that they understood the link between epilepsy and Taenia solium and how they were raising their pigs, because that was new information and people were fearful of epilepsy in the communities. So I'm going to say that maybe was one of the first most important pieces. It was very important that we did the training of the trainers model for two reasons. One, because then the information could be spread quite widely over a long time period by leaving the training behind. But the other reason was we trained public health extension workers. And so they did a wonderful job of explaining the importance of using a latrine and how that would then reduce the likelihood that somebody would get the Taenia solium. And finally, I would say that it needed to be the full package of the entire pig value chain, because clearly butchers were playing an important role. We were able to share with the butchers how much money they needed to save from one pig to the next in order to pay for the slaughter inspection. And then, as you saw, the community members no longer wanted to buy pork that wasn't inspected. So it was by training everybody, I think we were able to get that kind of community response. I think one more thing I will say, and I think this is for any One Health project in a community, it's so important to find out what the community wants before you start the project. They didn't want us to teach them about Taenia solium because they didn't know anything about the fact that there was a Taenia solium. So the farmers wanted to know how to feed and breed their pigs and how to raise a more healthy pig. And the butchers wanted to know about business practice. So I really honestly believe that we got good response because we dealt with the things that they found challenging and they wanted information about. Thank you for that question.
Great, thank you. That actually leads well into our next question. Something that you did talk a little bit about, Cate, in your presentation with an example from feed. But looking beyond that, how does the One Health team's curriculum integrate local cultural practices or knowledge? And what impact do you anticipate this will have on the effectiveness of One Health teams in Rwanda communities? So I'd like to open that up to any of the panelists to provide some insight on that question.
Shall I start, perhaps?
Sure.
Yes. So understanding culture is incredibly important. One thing that happened when in our pre-research evaluation, we recognized that people lived in multi-generation compounds, and a man couldn't use the same latrine as a daughter-in-law. So they either needed to build another latrine or they needed to understand that perhaps they could share a latrine. And again, that the public health person could talk about that. As a Canadian who wasn't familiar with the area and couldn't speak the language, of course, I wasn't able to impart that information, but the local people could. So that was one thing that I would say. The other thing is they really didn't know how to feed a pig. And it was obvious they were living in poverty, and the children didn't have enough food, and so of course the pigs didn't either. So it was very important that we made a diet out of things that were freely available. And finally, another example is in Kenya, women were willing to put the time and effort into making this pig food because they got most of the money from the pig sale. But in Uganda, if it was a male-headed household, the women didn't get the money and they were not willing to put the effort in. So I think all those examples are understanding culture so that we know what we could recognize as solutions. Thank you.
I just want to add a few things to what Professor Cate has just said, and I will try to put it in the Rwandan context. So as Dr. Cate said, we have already started the training. And one of the feedback that we received from the trainees is that they would like us to give them some time before each session so that they can tell us what they've been doing and how people are receiving the services and the knowledge that they are sharing with them. I think that's something that is going to help us, understand more the knowledge and the culture and acceptance of the training that we are conducting. But also another thing that we will do is, as you saw, some of the activities that will be conducted, actually all of them will be done in the communities. So it will give us a clear view of what people would like to have, what knowledge they need to acquire, and how better to give it to them. Yeah. And I will also add that both trainers are actually from the region where we are conducting the training. So they know exactly what is going on there. Yeah.
Great, thank you, Prince. So Shiaka, you've answered a few of the questions directly in the chat, but I think it'd be a great opportunity to speak to them also for those listening. So just thinking about the first question, the question is, is transmission between manure from infected pigs to human or pig food an issue?
Actually, it's good that you are asking again the question because I realized that actually I had misunderstood the question. So the question is about the manure from infected pigs. So the manure from, the Taenia solium cysts are not shed into manure of pigs. So there's absolutely no risk, getting infected through the manure coming from infected pigs. We are talking about fertilizers in terms of human fecal matters, because the humans can be infected by the adult tapeworm, in which case they can shed eggs of Taenia solium. So the pigs are not shedding eggs. They just have, the metastasis of Taenia solium, which is not shedding any eggs in their feces. So there's no risk to what, there's no risk from feces from infected pigs to human or pig food as such. So sorry for the misleading answer that I had previously given. I was considering that he's talking about human feces because they can be an issue since they may contain eggs from Taenia solium.
Great. Thank you. Thank you for the clarification. There's a whole bunch of questions in the question and answer. We'll do one more and then pass it to the panelists to just share one final kind of key highlight takeaway from this webinar before wrapping up. And any unanswered questions, we'll follow up with the recorded video, so that you can have any answers to any ones that we might not have gotten to. This last one from John Bosco, it's for Dr. Shiaka. How can you describe the uptake of healthy behaviors in the communities? Any contribution of local leaders, community health workers, religious leaders, teachers? How are they engaged to support the risk, communication, and behavior change?
Yeah, that is an excellent question, especially coming from John Bosco, who is a specialist of MTD. Thanks for the question. We are currently planning to really work with various stakeholders, from the central government, as I have shown, local government, but also really involving people in the communities where we will be implementing activities. We are planning to work with the community health workers because we know their role in vehicling, the message, especially health message, to their neighbors. We want also to work with the community animal health workers because we know we are pretty much aware of their role taking care of pigs, and we know that the people value, their pig production enough so they can, listen to these community animal health workers. We thought of working also with the members from community hygiene clubs, and we may actually be expanding, the reach to religious leaders, why not teachers, as you are suggesting. So this is really open, and actually my talk was showing that we need really to expand our reach and have everyone involved as far as we want to really change the behaviors in the community. I hope I have answered you.
Great. Thank you, Shiaka. So now I'm just going to ask each of you to keep a very quick final remark in about 30 seconds or less. So if we could start in the same order of the speakers today, if I could pass to Cate to go first.
So the thing I'm most excited about, I think, is having One Health teams work in the community. They said that was one of the exciting parts of the first training session, that they recognized that working together was going to get them farther in the community than working alone. And so there seems to be an energy to do that. So that's what I'm most excited about.
All right. Thank you, Cate. I think I'm also excited about this project, and I was excited from the beginning. And the reason why is we are talking about training the community-based workers, but in turn, what you will see is that we will also be learning a lot from them because they know the context, they know what they've been doing. And when you see the transformation that happens after, it really enlightens you. So that is what is exciting me at the moment.
Yeah, thank you. I'm equally excited, like my colleagues. We have been doing this Taenia work in the past, especially, trying to track the level of infections in various settings, including in slaughterhouses, but also in the community. It's very important to provide those kind of baseline data. But again, you ask yourself a question, what next? How can I better support the community that want really to see their pigs safe from the infection? How can I support, the humans, to cut the chains of infection with the Taenia. I'm particularly interested in this project because we have an opportunity to bring about change. We have an opportunity to do interventions which can support the local initiatives toward eradication of Taenia. I'm looking forward to the great collaborations that we have with our partners, and let's see how we can fight Taenia.
Great. And on that note, I would like to thank all speakers for sharing your insights on community-driven health initiatives, collaboration, and the power of the One Health approach, as well as thanking everyone in the audience for joining us today, for your attention and participation. As we mentioned, we'll send a follow-up email with a link to the webinar replay and any unanswered questions. So we encourage you to stay engaged in our One Health work and other VWB projects by visiting our website or following our newsletter. So thank you all once again. And with that, we're going to wrap up the end of our webinar. Thank you all. Bye.